So the video, which will begin shortly, has details of all these concepts. When you're watching it, observe the modes of ventilation, note the measurement of the plateau pressure, watch the parts of the ventilator, watch the filter that you're using. It's a air filter that clears up the air and purifies it, and note the alarms. The modes of ventilation, these are the abbreviations we'll be using: volume control, assist control, pressure control, synchronized, intermittent, mandatory ventilation, continuous, CPAP is continuous positive airway pressure, and there are many other modes. Your initial settings you'll be setting are, you'll be setting a tidal volume, you'll be setting a rate, you'll be checking something called the PEEP, the oxygen level, the mode, and what are the alarms, and something called the I to E ratio, inhalation to exhalation ratio, and a trigger. Let me just talk to you about I to E ratio. It is how many times you breathe a minute. Each breath is divided. Say you breathe 20 times a minute. 1 minute has 60 seconds. So if you're breathing 20 times a minute and you're breathing for 60 seconds, then you have a 3-second breath. And as you have a 3-second breath, you're going to be determining how much is oxygen and how much is exhalation. So inhalation, exhalation can be 1:2, which means that you're having a relationship between oxygen and carbon dioxide to be 1:2. And then you can also determine your trigger, which is what is it is making the machine actually trigger your breathing, and what is the machine going to know in terms of what triggers the machine to send the breath to you. It can be a drop in pressure. When you take a breath, you're going to have a negative pressure. The machine will say, you know what, he wants oxygen, he wants air, and the machine will open a valve and it will immediately push it through. So we are quickly summarizing here. We've gone through anatomy, physiology, the concepts of ARDS. We talked about why ARDS management is important and the high mortality. We talked about the concept of what tidal volume to use, why to measure plateau pressure, and we talked about why we need to use the different modes of ventilation. When you adjust the ventilator, you base it on an ARDS. You also need to base it on an ABG. And we'll also be needing to review the PEEP FiO2 table. And a PEEP FiO2 table is something that is important as you start requiring higher and higher amounts of oxygen. Now, there are non-invasive ventilators involved using a face mask, and they help you deliver oxygen. However, in COVID-19, most of the time, they are recommending not to use it. They are recommending invasive ventilation. There are situations where you have to consider using non-invasive ventilation. You also need to figure out that an invasive ventilator is connected to an endotracheal tube. That is a whole separate area where the size of the endotracheal tube matters. We also need to have a situation where you may need long-term ventilation after they've recovered, where you need a tracheostomy, which is essentially oxygen being connected to the neck. You also need to have a situation where you don't use a ventilator, but use something called high flow oxygen, which has a lot of benefits. And you have to also adjust the oxygen in a ventilator so that you give enough, but not too much. So these are all concepts you learn about. Many patients need sedation because they will not find it comfortable to breathe. And sometimes you even have to paralyze these patients so they are completely not able to move. Ventilators can be dangerous. They can cause infection, and you have to be careful and be very cautious about infection control, like washing your hands, covering your mouth, not touching your face. When you're doing suction, keeping it closed. Now, keeping the head of the bed over 30 degrees will help prevent ventilator-associated pneumonia. They have done very interesting studies using radioactive materials. They injected into somebody's, they put in the stomach, and then they saw where did the radioactivity go. Depending on the angle of the patient, they found that at 30-degree angle, very little goes into the lung. Otherwise, a lot of it is ending up in the lung. Also, all the tubings that are connected, don't change it unless it's very, very soiled or dirty. Otherwise, you should continue the same thing, and use inline suctioning, which means do not disconnect the circuit because it's very high risk of spreading the infection. Now, the reason you guys are going through the training is concepts of barotrauma. Too much pressure in the lung can cause damage. Too much volume can cause damage. Ventilators can cause pneumonia. You need to know how to attend to a very specific alarm called a peak inspiratory pressure alarm. You need to know how to attend to an alarm where there's a low tidal volume alarm. You also need to know about a ventilator getting disconnected. How do you reconnect it? And you also want to learn about patient ventilator synchrony. Now, these are pretty much the reasons that you will need to learn how to use a ventilator, and we'll learn how to do it in 2 minutes or so. So when you have the synchrony issue, meaning the patient and ventilator are kind of having issues, you have to ask the question, did I set the wrong setting? Is there something wrong with the patient, or is there something wrong with the machine? So for example, you did not give enough tidal volume and the patient wants more, or you did not allow the air to go in at a fast enough rate, or you put the rate of breathing to be too fast, or perhaps the patient has a collapsed lung or a full bladder, he's having pain, or you're not sedating him enough. So now I'm going to request Dr. Shravani to initiate the video, and I'm going to give 30 seconds if somebody wants a quick question to answer before we proceed. So what we have done today so far is review all about ventilators, and we've talked about what needs to be done. And I think we can go ahead and initiate.